Good morning. Our lecture today will be about hemorrhagic disorders. I'm Dr. Nihad and I will give you this lecture today. The first part of the lecture will be a brief recall of the physiological mechanism of the hemostasis. This will facilitate the understanding later on of the hemorrhagic disorders. Intact blood vessels are central to moderating blood clotting tendency. Whenever there is a breach in a vessel, we will have the coagulation factors, the platelets, working together so that at the end of the day, the flow must be maintained. Hemostasis derives from the Greek meaning, which means the stoppage of blood flow. And for hemostasis to occur, it can be divided into two stages, primary or secondary. Primary hemostasis will include the platelet and the vascular response to vessel injury. Secondary hemostasis will include the coagulation factor response to this vessel injury. So together, platelets, vessels, and coagulation factors will combine to stop the bleeding and allow for vessel repair through the formation of a stable fibrin platelet plug at the site of the injury. What happens when there is a breach in the vessel? When there is a breach in the vessel, the endothelial cells will release von Willebrand factor in the circulation. This von Willebrand factor will cause platelets to adhere to the vessel, like shown here. And once the platelets will adhere to the subendothelia, to the denuded subendothelial collagen, this will cause the platelets to be activated. When platelets are activated, they will swell, they will grow filaments, like it's shown here, and this will allow the platelets to aggregate or to coagulate together to form a fibrin plug. Stimulation of the platelets will cause the platelets to release the content of their granules, which is thromboxane A2, ADP, serotonin, fibrinogen, and thrombospondin. These molecules will attract more and more platelets that will aggregate more and more and form a platelet plug that will seal the breach at the site of the injury. This will be the platelet part of the stoppage of the hemostatic mechanism. But parallel to this one, there will be stimulation of the coagulation cascade. The coagulation cascade will end by forming a stable fibrin, a stable platelet clot, through forming a mesh of fibrin that will hold together in a stable form the platelet plug with this fibrin mesh. The coagulation cascade includes two parts, the extrinsic pathway and the intrinsic pathway. I will start here with the extrinsic pathway. The role of the extrinsic pathway is to generate a burst of thrombin rapidly into the circulation to reach rapidly the formation of prothrombin and thrombin into the circulation. How this will be started? When there is a breach in the vessel, there will be release of something called tissue factor. This tissue factor will immediately activate factor 7 into factor 7A. This factor 7A will rapidly go into the common pathway, which will start with factor 10. It will activate factor 10 to become activated factor 10A, which together in the presence of factor 8 will help the release or will cleave prothrombin into thrombin to generate the most important molecule of the coagulation, which is the fibrin. Fibrin will be cleaved from fibrinogen through thrombin. So this is the part of the extrinsic pathway. The extrinsic pathway or the tissue pathway will work parallel with the intrinsic pathway. But as I told you before, the extrinsic pathway is to generate a burst of thrombin very rapidly into the circulation. Now, how the intrinsic pathway will work, or the contact pathway, it will start with the factor 12, which will become factor 12A or activated factor 12A, then this one will activate in the form of a cascade successively factor 11 into factor 11a. Together with the presence of factor 8, we will end at the end of the day with activation of factor 10, which is the common pathway with, again, activation of prothrombin into thrombin, acting into fibrinogen and cleaving it to release the last product, which is the fibrin. So, in resume, the coagulation cascade, we have two pathways, the extrinsic pathway and the intrinsic pathway, ending in the common pathway, and the aim is to activate factor 10 through the common pathway together with factor 8 to release our product, to activate our product, which is the prothrombin, to release the thrombin, which will act on fibrinogen, releasing the fibrin monomer. Now we will come to the hemorrhagic disorders. Hemorrhagic disorders are disorders characterized by abnormal bleeding tendency due to hemostatic defect. The hemostatic mechanism in hemorrhagic disorders will not go through a normal pathway. There will be a defect. So, before going into the details of hemorrhagic disorders, I will remind you. For the hemostatic mechanism to occur, we have several mechanisms that will help the breach or the bleeding to stop. First of all, the vessel, then the platelets and the coagulation factors, then the coagulation inhibitors and the fibrinolysis. We will take each one in details. The vessels. How the vessels will put their share in the hemostatic mechanism. First of all, local vasoconstriction or a reflex vasoconstriction. The vessels will be constricted so that the flow of blood will be decreased at the site of the injury. Then there will be initiation at the vessels of the intrinsic pathway through activation of the factor 12, like I already said. There will be also activation of the extrinsic pathway through the tissue thromboplastin or the tissue factor that will activate factor 7. There will be promotion of platelet adhesion and aggregation because at the end, the site of attachment of the platelet is the vessel and the site of aggregation of the platelets is the vessels. And the site of the release of von Willebrand factor is the endothelial lining of the vessel at the site of the injury. The platelet. How the platelet will contribute to the hemostatic mechanism? First, by platelet aggregation through the von Willebrand factor and by platelet aggregation through the release of the molecules or the content of the platelet granules. Then will come the coagulation factors that are activated through the extrinsic and the intrinsic pathway, ending by activation of factor 10. And then the active thrombin will be generated, which will cleave the fibrin from fibrinogen. Now the coagulation inhibitors. The coagulation inhibitors, they circulate in the plasma and they are bound to endothelium and they are here to prevent unnecessary widespread coagulation throughout the body once the coagulation has been initiated. They include protein C and antithrombin. Then the last thing is fibrinolysis. We have to remember that once the platelet plug or the clot is formed, it will not stay here forever. It has to be degraded at the end. And the fibrinolysis is the process that will limit fibrin deposition at the site of the injury due to activity of a key enzyme called plasmin. It will degrade the fibrin and it will destroy the clot to prevent unnecessary excessive clotting formation. So in resume, we have the intrinsic and the extrinsic pathway. Here, this slide is meant to tell you how we will assess the extrinsic and the intrinsic pathway in the lab. The extrinsic pathway will be assessed through prothrombin time, which is 11 to 14 seconds. The intrinsic pathway will be assessed through the partial thromboplastin time, and the common pathway will be assessed through the thrombin time. Now we will go in details through the hemorrhagic disorders. I will tell you before starting with this one, there are some topics like immune thrombocytopenic purpura and Henoch-Schönlein purpura that will be discussed in details, in full details in the rounds. So I will not go into the details of these topics that will be later on fully explained in the rounds. Bleeding tendency. and coagulation diseases. These are the two main problems in hemorrhagic disorders. For the bleeding tendency, they will include platelet problems or vascular problems. I will start with the platelet problems. Platelet problems or platelet disorders will be either a decrease in the number of platelets or thrombocytopenia, or a problem in the function of the platelets or platelet dysfunction. We will start with thrombocytopenia or decrease in platelet number. The decrease in platelet number will be either due to increased platelet destruction or impaired platelet production. The increased platelet destruction is either immune or non-immune. Immune, like in systemic lupus erythematosus, with formation of autoantibodies to platelets, and ITP or immune thrombocytopenic purpura, which is the most common problem leading to thrombocytopenia in children due to formation of autoantibodies following a viral infection, and this one will be discussed in full details in your rounds. Non-immune, like hemolytic uremic syndrome. Hemolytic uremic syndrome often occurs after a gastrointestinal infection with E. coli bacteria. It is a condition that will affect the blood and blood vessels. It will result in the destruction of blood platelets, a low red blood cell count, and kidney failure due to damage of small blood vessels. Disseminated intravascular coagulation, I will discuss this one later in this lecture in full details, and hypersplenism, which is a common disorder characterized by rapid and premature destruction of blood cells in the spleen. Impaired platelet production. In impaired platelet production, we have Fanconi anemia, which is autosomal recessive, and it is the most common inherited form of aplastic anemia. The majority of these children will present with congenital anomalies as short stature, abnormal radii, sums, and renal malformation with microphthalmia. Viscott-Ulrich syndrome, which is also an autosomal recessive condition with low platelet immune deficiency and bloody diarrhea secondary to thrombocytopenia. Then the acquired forms of impaired platelet production, like aplastic anemia in children with chronic hemolytic disorders as thalassemia, secondary to infection and suppression of the bone marrow after a viral infection. Marrow infiltration, like in storage diseases, or by infiltration of the bone marrow from malignant cells secondary to a primary malignancy. Drug-induced, like in children using, there are some drugs like quinine or like sulfa, or some anticonvulsant drugs like that will cause impaired platelet production and suppression of the bone marrow. The second problem in platelets will be a platelet dysfunction, as in inherited problems like Glanzmann disease. And in Glanzmann, there is a defect in the surface glycoprotein of the platelets, or von Willebrand disease with deficiency of the von Willebrand factor. I will also discuss this one later in this lecture. Or acquired disorders with drugs like acetyl salicylic acid that will impair platelet adhesion and aggregation, and in cases of uremia in children with chronic renal failure. Now, the vessels. We can have a problem in the vessels that can be inherited, like in Ehlers-Danlos syndrome, and it can be acquired, as in cases of vasculitis. And one of the most common vasculitis problems occurring in children and leading to bleeding tendency is Henoch-Schönlein purpura. We will take this one in the rounds. Metabolic infection in subacute bacterial endocarditis in children with congenital heart diseases. Collagenic, like in systemic lupus erythematosus with formation of autoantibodies to platelets, and scurvy or vitamin D deficiency. Coagulation diseases, we will start with the hemophilias, hemophilia A, B, and C, or acquired, like in disseminated intravascular coagulation. I will discuss this one later. Hemorrhagic disease of the newborn. Hemorrhagic disease of the newborn, you will take this one in the neonatology section. This will be due to vitamin K deficiency in the newborn patient. Liver diseases, as you know that the liver is the major site of production of most of the coagulation factors. and in children taking anticoagulants, although this one is a little bit rare in children. How to test for coagulation and bleeding? We will start with a CBC to assess the platelet count. We will assess the platelet function, thrombin time, prothrombin time, PTT, quantitative fibrinogen assay, and D-dimers. Now, I will discuss some hemorrhagic disorders, the most important hemorrhagic disorders in children. Hemophilia. Hemophilia A. This is an X-linked recessive condition. And before telling you what is hemophilia, I will tell you that hemophilia is due to deficiency of factor VIII. But actually, factor VIII has two components. It has an antigenic component, which is the von Willebrand factor, and a procoagulant component, and this procoagulant component is the one that is missing or deficient in patients with hemophilia A. And it is very much decreased in patients of hemophilia A. The antigenic component or the von Willebrand factor in hemophilia is normal. So, and we will classify hemophilia A according to the severity of decrease or defect in factor VIII. It will be severe if the patient keeps only 0 to 1% activity of factor VIII, moderate if you only have 1 to 5% of factor VIII activity, mild if he has 5 to 25% activity, and it can be in carrier female, and they will keep around 50 to 60% of the activity of factor VIII. Hemophilia A. The patient with hemophilia A will have a positive family history. They present during the neonatal period with bleeding from the umbilicus or bleeding during a circumcision, abnormal bleeding when they are circumcised, or more severe with intracranial hemorrhage. In infancy or in children, when the child starts to walk, the presenting symptoms will be mainly hemarthrosis in the bleeding joint, in the weight-bearing joints like the knee, especially the knee. There can be also other types of hemorrhage, ecchymosis, intracranial hemorrhage, intramuscular hematomas, bleeding from any site. To diagnose hemophilia A, PTT will be prolonged because here the part that is affected is the intrinsic pathway due to deficiency of factor VIII, which is involved in the intrinsic pathway of coagulation. PT here will be normal because factor VII here is normal. Factor VIII assessment will show a reduced amount of factor VIII. The prenatal diagnosis here will be done through chorionic villus biopsy, and these families will need a genetic counseling. How we treat hemophilia A? First, prevention. We have to avoid trauma, we have to avoid intramuscular injection, to avoid surgery, or to prepare the child to surgery with proper factor VIII replacement. Non-violent exercise, avoid aspirin. We have to prevent blood-borne infection due to the blood products that we will give intravenous to the child. So we have to do a proper screening of these blood products, and we have to immunize the child against hepatitis B virus. Education, of course, and psychology. The most important part of the treatment of hemophilia is through replacement therapy. How we will replace factor VIII? We can replace it through providing the patient with plasma rapidly to stop the bleeding, or cryoprecipitate, giving factor VIII concentrate or recombinant factor VIII concentrate, which is safer because it doesn't entail the risk of blood-borne infection. Factor VIII concentrate dose will vary according to the site of the hemorrhage and according to according to the severity of the hemorrhage. The side effect of providing this blood product to the child will be isoimmunization with hemolysis due to anti-A and anti-B antibodies, infection, AIDS, hepatitis B and C, and the most challenging part is the development of factor VIII inhibitors. Factor VIII inhibitors are a consequence of treatment, and patient will develop this inhibitory immunoglobulin G antibodies to factor VIII, which are called inhibitors. Local measures, of course, like cold compresses, and drugs like epsilon alpha aminocaproic acid, which are antifibrinolytic drugs. They are given to help the fibrin clot to be stable and to prevent its degradation. or desmopressin in mild and moderate cases of hemophilia, it can be very effective because desmopressin will help the release or will promote the release of von Willebrand factor with subsequent increase of factor VIII survival secondary to von Willebrand factor complexing in patients with von Willebrand disease in mild hemophilia A. Actually, the antigenic part and which is von Willebrand factor will complex the factor VIII so that it will not be degraded rapidly in the circulation. And treatment of inhibitors is an important part. How we will treat inhibitors? We will treat inhibitors by giving very high doses of factor VIII or by exchange transfusion to remove, or plasmapheresis to remove this unnecessary immunoglobulin G, by giving factor VII concentrates, and here we are bypassing the intrinsic pathway and we are bypassing the stimulation of the coagulation system through the factor VIII by bypassing this factor VIII and stimulating the coagulation mechanism through the extrinsic pathway by giving factor VII concentrates, or by giving directly activated prothrombin complex concentrates, which are called FIBA, also to bypass the stimulation of the intrinsic pathway. Hemophilia B, or Christmas disease, it is present in 50% of cases. It is also X-linked, the same lab as hemophilia A, because here the defect lies in factor IX concentrates, but the treatment will be through providing factor IX and not factor VIII. Now I will come to the von Willebrand disease. Von Willebrand disease is an autosomal disease. It is due to deficiency of von Willebrand factor primarily, and in some cases there is also deficiency of factor VIII. Clinically, there is a bleeding defect mainly due to von Willebrand deficiency, which is involved in the platelet aggregation and in the platelet adhesion, and there can be also a coagulation defect if the factor VIII procoagulant factor is also concomitantly decreased in case of von Willebrand disease. So we have prolonged bleeding time mainly, and sometimes prolonged clotting times if factor VIII, the procoagulant part of factor VIII, is also decreased. Of course, there is defective platelet function, adhesion, and aggregation due to the defective von Willebrand factor. The treatment here is through plasma and cryoprecipitate factor VIII concentrate with high content of von Willebrand factor, and through providing desmopressin, which will help the release of von Willebrand factor from the endothelial cells, and also providing antifibrinolytic drug like alpha-aminocaproic acid. Here, this table is meant to make a little bit comparison between von Willebrand factor and hemophilia. Von Willebrand factor is mainly a problem of platelets. So here the bleeding will be mainly in the skin and subcutaneous tissue with bruising and epistaxis. In hemophilia, there is a defect in factor VIII. So the problem here is in the coagulation process itself. So the bleeding will be deeper, like in joints and in muscles. It is hemophilia is an X-linked recessive, so it will affect more males. And the inhibitors are mainly developed in hemophilia, not in von Willebrand factor, because it is an IgG antibody to factor VIII. The bleeding time is abnormal in von Willebrand factor. The PTT is much prolonged in hemophilia, and factor VIII is very decreased in hemophilia, can or cannot be decreased in von Willebrand disease according to the defect. Von Willebrand factor is the major one affected in von Willebrand disease, and it will be decreased or absent in von Willebrand disease. We are coming now to the DIC, or the disseminated intravascular coagulation, which is a widespread deposition of fibrin and microthrombi. And here there will be consumption of coagulation factors, and the consumption of the coagulation factors will lead to bleeding. Also, there will be tissue ischemia and necrosis due to obstruction with this microthrombi in the vasculature. Then there will be secondary hemolysis because there will be initiation of the body will not stay like this. The body will defend itself by trying to to lyse this extensive microthrombi through the microvasculature, so there will be declenchment or there will be initiation of this secondary fibrinolysis with bleeding, with secondary bleeding. What is the etiological factor of DIC? There are many clinical states that occurs in a variety of diseases. It is due to hypoxia, it is due to acidosis, endotoxemia, and this is the main problems. This is the major cause of DIC, with sepsis in severe bacterial infection, snake bite, and incompatible blood transfusion, promyelocytic leukemia. DIC. How we will diagnose DIC? DIC will be diagnosed by prolonged PT, PTT, and thrombin. All will be prolonged. Why? Because we have consumption of all the coagulation factors through this widespread coagulation inside the microvasculature. The platelet count will be decreased because it will be consumed in the multiple clots. The fibrin degradation products will be very increased, and the fibrinogen also will be very decreased because it will be consumed. We will see in the CBC Burr and helmet cells, which are fragmented RBCs due to their entrapment and in the fibrin meshwork. D-dimer. D-dimer is an important tool to diagnose DIC. This is a new antigen that is forming during the process of digestion of fibrin, and it is very characteristic of DIC. The clinical picture of DIC will be first the clinical picture of the underlying disease, which is mainly sepsis, the clinical picture of the bleeding, GIT, pulmonary hemorrhage, petechia, bleeding everywhere in the body, and the clinical picture of thrombosis and necrosis. There will be obstruction of the microvasculature, so there will be convulsions due to obstruction of the microvasculature in the brain, gangrene, and renal failure. The clinical picture of intravascular hemolysis with microangiopathic hemolytic anemia due to entrapment of the RBCs in the fibrin meshwork. How we will treat this one? We will treat it through control of the original disease, which is mainly sepsis, providing blood components, plasma, platelet transfusion, cryoprecipitate, heparin in peripheral, exchange transfusion in newborn, providing antithrombin and protein C to help to stop the bleeding. I hope this lecture was very helpful for you. I only made the spots on the problems that can occur in children with hemorrhagic disorders. Thank you.